Also welcome from my side. Thank you for inviting and having us today for today's Journal Club, where Kerstin, Eva and myself are going to present a study protocol that we developed over the past years and which we're actually in the process of carrying out. So let me start with setting the scene before I'm handing over to my colleague Kerstin. So as all of us, we were all part of a big natural experiment happening over the past years. The pandemic that we're still kind of part of, although it seems like it's getting better, whatever that might mean. And there was a strong postulate in the public realm to make use of the best available research evidence when making decisions, for example, when to use masks, how long to quarantine, and so forth. The reason why evidence-informed decision-making has been postulated is that using the best available research evidence in decision-making is assumed to lead to more effective and efficient interventions, which is of particular importance in settings where resources are scarce and where there's a high burden of disease, for example, in low and middle income countries. It is also assumed to lead to more cost-effective decision-making. And in general, there's more trust in decision-making if research evidence is used in a transparent way and where there are appropriate consultation processes being involved in decision-making. However, as all of you know, research evidence is not the only thing that has to be considered when making decisions. So there are other aspects such as habits and traditions, lobbyists and pressure groups, pragmatism and consistencies, professional experience and expertise, political judgment, resources, of course, and values. And all of these forms, they look very different when it comes to like the form of evidence they come in or the form of expertise they come in. And the best available research evidence, as we in research know it, might not look exactly the same as all of these other very important things that influence decision-making. Also, we have to be aware that evidence decision-making in general is just not that linear process that we like to envision this process to be. So getting research evidence into policy and practice is one of the big interests of a research field, which is called knowledge translation. And in knowledge translation, we characterize more or less 4 ways of how we can move research into decision-making. The first one is the very classical one that you all are probably familiar with. We as researchers, we produce research outputs, we publish in scientific journals, we might even produce policy briefs or issue briefs, which then lead in, enter the decision-making process and are somehow turned into a policy. The second pathway is a pathway where, which we call push or pull effort. In that case, decision makers turn to us as researchers, which is something which happened quite frequently during the COVID-19 pandemic, asking for the latest evidence on what works when we want to prevent the transmission of SARS-CoV-2 in schools. And we produce some form of evidence output that can be used in decision making. The third form is a more more exchanging and collaborating mode, which is called exchange efforts, where we're kind of circulating between the research production and the research utilization and decision-making process, which can take various forms. The fourth form is the integrated efforts, where we're actually trying to meet in a common space and work together between research producers, us researchers, and the decision makers that actually have to make use of the research evidence we're producing. And in particular, this fourth form of knowledge translation, of translating research evidence into practice, this is the particular form we were interested in. Integrated knowledge translation is something which we describe as a continuous ongoing relationship between a researcher and a stakeholder, which is in the case of integrated knowledge translation, a decision maker. So it can be a politician, but it also can be a clinician, a manager in some form of healthcare provider organization. And we are engaging in a process with stakeholders for the purpose of engaging in a mutually beneficial research project or program that is intended to lead to more relevance in the research evidence that we're producing, It is supposed to lead to higher implementation of the research results that we're producing. It also is supposed to lead to a higher implementability of the research evidence we're producing, meaning that it meets more the needs of decision makers in a specific context. And lastly, it's also supposed to lead to sustainable partnerships between researchers and stakeholders. Please note that one of the most important aspects of the integrated knowledge translation approach, as I just described it, is that it's supposed to be continuous. So it's supposed to start from the very beginning, and it's supposed to continue over the entire research process, from defining the research question up to actually carrying out the research you're interested in. Integrated knowledge translation has been around for a couple of years now. However, does it work to lead to all of these outcomes that I'm just showing to you, are less certain than we would like to assume. And in particular, there are high quality evaluation missing that have been carried out in low and middle income contexts. So most of the evidence we have on integrated knowledge translation stems from the Northern American continent, and less so from low and middle income countries. There's little longitudinal assessments being carried out. And this is where we as SEBA Plus set off to carry out our research. And with that, I'm handing over to my colleague, Kerstin.
Yeah, thanks, Lisa, and also a warm welcome from my end. Let me jump right in to talk about how we're doing integrated knowledge translation in SEBA Plus and how we are doing research on integrated knowledge translation in SEBA Plus. This should now be in presentation mode, I hope. Thanks, great. Okay, so actually Eva, Lisa and I are part of the SEBA Plus research network, which stands for the Collaboration for Evidence-Based Healthcare and Public Health in Africa. And this is a research network with partners in Germany and then 5 countries in Eastern and Southern Africa. And we're focusing on the prevention and care for non-communicable diseases, so NCDs, as well as the prevention of road traffic injuries, which presents a big burden of disease in the context of sub-Saharan Africa. And SEBA Plus is one of 5 research networks that's currently funded by the German Federal Ministry of Education and Research. And as such, it is part of Germany's attempt to become a bigger player in global health research, and it's part of Germany's global health research agenda. SEBA Plus has been around since 2017, so we're actually nearing the end of our project, just for the context of this research. And now, as Lisa said, there has been an attempt to bring in the expertise and perspective of decision makers from the start of the project. So when the proposal for SEBA Plus was written, our researcher colleagues who were drafting the proposal undertook a priority setting exercise with decision makers, in particular policy makers from the African partner countries. And they came up with this collection of priority research areas that were of concern for the partner countries in sub-Saharan Africa. And obviously that's a lot of topics, the lighter shaded boxes being diseases and the darker shaded boxes being risk factors for those diseases. So they were obviously not able to take on and tackle all of these research priorities. So they continued their priority setting and eventually focused on heart disease, diabetes with their associated risk factors, as well as the road traffic injuries. All of those topics being topics that are not necessarily researched a lot in the respective settings, whereas, for example, there is already quite a bit of research on infectious diseases. Now, to then continue including decision makers in the research project, there was an attempt to formalize stakeholder engagement in SEBA Plus. So when we're actually now talking about stakeholders, we mean decision makers, so people with decision-making power who can act on the evidence, but we also mean other groups of stakeholders, which are also involved at some of the SEBA Plus sites. So in order to choose which of these stakeholder groups to engage with throughout the research process, there was a first step of identifying stakeholders that were active in at the African SEBA Plus sites, and then moving from that very long list of stakeholder groups and individual stakeholders that somehow had a stake in the SEBA Plus research topics, the SEBA Plus colleagues moved to analyzing those stakeholders, and this means looking at how interested is a particular stakeholder in this research topic and how much power do they have. And as you can see in this visual, this is already informing decisions as to how much to engage with a given stakeholder. So is this someone with high interest, high power, whom we want to invite to workshops and invite to stakeholder meetings? Or is this someone whom we send an email every 2 years? So based on that analysis step, the next formal step included drawing up a stakeholder engagement matrix, which basically delineates the plans for engaging the stakeholders. So writing down whether we want to send that email to the stakeholder or actually hold a workshop with a group of stakeholders. And this is what we then termed the IKT strategy for engaging the stakeholder throughout the research process. And the next step of this IKT approach includes monitoring and evaluation. So monitoring of stakeholder engagement activities in SEBA Plus. And then the evaluation is what Lisa and I are concerned with, which we're going to talk about now. And going briefly looking at this visual from our paper, as you can see, this process of developing the IKT strategies is then followed by continuous implementation of the IKT strategy. So continuous stakeholder engagement based on what was predefined in the IKT strategy, in addition to monitoring and evaluation. And as you can see, or as you may understand from what we have been explaining, the IKT approach and SEBA is thus conceptualized as an intervention in itself. And so in order to conceptualize how this intervention works, Lisa and other colleagues at the LMU have developed this program theory, which at its core being the relationship building with stakeholders, the collaborative research, and capacity building of stakeholders as core intervention tenets. And then we're hoping that this leads as an intermediate outcome to a higher value of research evidence in the perception of the SEBA Plus stakeholders, a higher intention to use this evidence, more consideration of research evidence in actual decision making, and then ultimately to an increased use of research evidence in decision making. This, of course, is nested, or very much so nested in context, which differs across the African SEBA Plus implementation sites, and which is something we're paying particular attention to in our evaluation efforts. And now, as I said, this project is nearing its end, so we're approaching the final evaluation stage, but for now, the results that we can present are very much based on like a midterm evaluation. So we can talk about how the evaluation so far has focused on understanding how this intervention has played out at the SEBA Plus sites, like how these core components have actually worked. And then secondly, we have looked at different implementation outcomes and hoping to be able to say more about intervention outcomes in the final evaluation step. So just briefly summarizing the methods, as I said, there's the 2 evaluation stages. And in terms of methods, we are drawing on key informant interviews, an online survey, and document analysis for this evaluation. And now I would like to talk about some general learnings from our SEBA Plus IKT approach, and then some more specific results of the evaluation that we've already seen. So overall, across the project, there's been great enthusiasm about systematic stakeholder engagement / IKT. And we have seen that at all the African implementing sites, successful partnerships have been established. And these partnerships are quite diverse, which shows that the IKT strategies have been tailored to local contexts, and that the partnerships that have arisen in this project are very much tailored to the needs and preferences of our SEBA Plus colleagues and their partners. So the enthusiasm is on the one hand side and the partnerships, but then obviously this project has seen the challenges of COVID, which in some cases has meant that all stakeholder engagement has stalled. But on the other hand, there's been quite a few cases in our research project that COVID has actually given an opportunity for stakeholder engagement. So both options are there. But then obviously it has led to more conflicting priorities, and already for which is a common problem in KT, the researchers are supposed to be doing and want to do their research. So stakeholder engagement somewhat competes for their time. So that's been a challenge. And then we've seen some staff turnover, both at the side of the decision makers, at the side of our African SEBA Plus colleagues, and also at LMU. So that's very tricky with an approach that is supposed to be continuous, obviously. And then lastly, in terms of general learnings, we have seen that this systematic nature of the IKT approach was something novel that was happening at the implementation sites, but that stakeholder engagement generally was quite common and was something that our colleagues were very familiar with, because it was the normal part of their normal business of doing research to also engage with local stakeholders. This means, though, that it's tricky in the evaluation to differentiate between effects that arise from the standard practice stakeholder engagement and this add-on formal approach that was added to it. And another aspect that's quite important to keep in mind is that also across the project, there's a bit of positivity bias. So we're all really inclined to look at the positive effects of IKT or stakeholder engagement more broadly, but we're all less inclined to look at the unintended consequences and potential harmful effects. So that's something we have learned. In terms of implementation outcomes, we learned that the initial stakeholder mapping and drafting of the IKT strategy was undertaken by all implementation sites, but then over time, it had been envisioned that these would be monitored and updated, and that hasn't happened so much. And it's our colleagues have also fed back that the approach to stakeholder engagement that they ended up using was way more flexible than what they had initially envisioned in their IKT strategies. In terms of acceptability, the IKT approach was by some SEBA colleagues in Africa perceived as a very Western concept, or as a fancy new label for something they had been doing all along, as I said earlier. And then in terms of acceptability, what has also been tricky is our role as German evaluators, where the fact that this is a research project where the implementation sites are in sub-Saharan Africa, but there's also German partners, it has opened up the opportunity to undertake this research on IKT, but it also has us in this position as being foreigners to the African context, with an understanding that's always limited in terms of how these partnerships work in the African countries. And then also within the SEBA Plus team, being evaluators has put us into a tricky role. So that's also something that we're seeing, that we're learning from, and hopefully carrying forward to our future research projects. Leading to these takeaways. So in particular, with planning such an evaluation in an international research project, it requires quite a bit of consideration of the resources and the implications for the research partners. And now, lastly, what we know so far in terms of benefits of this systematic IKT approach, it has allowed our colleagues to allocate scarce resources more wisely by deciding on which stakeholders to invest in and which stakeholders to deprioritize. And in particular for junior researchers, also such as ourselves, it's been an opportunity to learn stakeholder engagement by following this formal process. In terms of unintended consequences and harms, it's important to see that there's a substantial opportunity cost involved for researchers and decision makers engaging in stakeholder or engaging. There's a risk of overwhelming decision makers, in particular, since now a lot of research funding agencies require that researchers engage with decision makers, often requiring policy engagement. And obviously, if all the research projects in the country try to contact a handful of health policymakers, that is a substantial harm that needs to be dealt with. And then on the researcher side as well, though, it's the demands that decision makers within such a partnership place on researchers can just be way too much to handle, like undertaking the quick literature review that we all know is not usually quickly done, but can be quite resource intensive. So that's what we've learned so far. And I think before I hand it back to Eva and Esther, I was asked to finish this sentence. So from Lisa and my perspective, global health research is continuous work to establish equitable and mutually beneficial relationships between groups as researchers. And this means us and our African colleagues, researchers and research users, which is the partnership between the researchers and decision makers or the groups of stakeholders. And I just really want to emphasize that this is continuous work, and we are looking forward to continuing it. Thanks.